Professor Ryosuke Kuroda will give us topic of evolving management of first-time patellar dislocation. Please.
Thank you. Thank you very much. Thank you for introduction. Thank you very much for inviting this TOSSM. My name is Ryosuke Kuroda from Kobe University, Japan. Today, it's a great honor for me to be here today. I'm going to talk about the management of first-time patellar dislocation. So the first, I'd like to thank you to Bancha and Chanakan. We met in Milano, ESCA, this year, 2 months ago. We had a good time in Milano. So this is my disclosure. So the predisposing factor for patellar instability is there are many factors: patellar tilt, patellar shape, J sign, Q angle, alignment, tubercle malposition, and trochlear dysplasia, patellar alta, and anteversion of femoral neck, and many factors. So the image is also very important to find the abnormality of patellofemoral joint. TT-TG distance is one of the key to the position of the patella, and also de jure classification is very important. There's 4 types, A, B, C, D, and especially C and D is a very bad patellofemoral condition. And also patella alta is an important factor. Condition index we use for the patella alta detection. The abnormal is over 0.3. So the management of acute first-time patellar dislocations, probably you do a conservative treatment for the first-time patellar dislocation, but recently there are several meta-analysis and systemic review. The MPFL reconstruction resulted in lower rate of redislocation, 7% versus 30% in the rehabilitation non-surgical group, and also a high Kujala score compared to the rehabilitation group. So this paper recommends surgical intervention for first-time patellar dislocation. And also MPFA reconstruction could achieve significantly lower redislocation rate and reoperation rate than MPFA repair in the first-time patellar dislocation. And surgical management should be performed in first episode of traumatic patellar dislocation patient practicing contact sports, and in those patients who present type C and D trochlear dysplasia and patella alta. So the guideline for MPF reconstruction has evolved notably during past 2 decades. And it is necessary in some cases to pair MPFA reconstruction with other surgical procedures, as Dr. Ishibashi demonstrated the surgical procedure this morning, and he also mentioned that additional surgical procedure. So the ideal indication of MPFA reconstruction is TTTG less than 20 millimeter, patella alta less than 1.2, and trochlear dysplasia is grade A. So additional procedure is such as tibial tubercle transfer, trochleoplasty, and derotational osteotomy. The medial patellofemoral ligament reconstruction is widely performed to treat patients with recurrent patellar dislocation and resulted in lower rate of redislocation in acute first-time patellar dislocation also. In MPFA reconstruction, femoral tunnel position is very important, one of the most important factors affecting clinical outcomes. So probably you use fluoroscopic to decide the femoral tunnel position. The Shoto reported this fluoroscopic guidance method, and 1 millimeter anterior to posterior cortex extension line and 2.5 millimeter distal to the posterior origin of the medial femoral condyle and proximal to level of the posterior point of the Blumen's line. So this is the Shoto point. The graft length change pattern at the femoral tunnel position determined by fluoroscopic guidance. Probably we discussed this morning, and what is the length change pattern? Is this isometry or what is the length change? So we did the clinical research to examine the graft length change pattern at the femoral tunnel position determined under the fluoroscopic guidance. 44 knees patient who had episodic patellar dislocation, performing MPFA reconstruction using semitendinosus tendon, putting 2 anchors in patella and 1 tunnel in femoral side. So the method of surgical technique is insertion 2 suture anchor in the patella, then inserted pilot pin into the position report by Shoto, true lateral view under fluoroscopy. Then we check the graft length change pattern. The length change pattern, if favorable, favorable means not long during flexion and slightly long during extension. So this is the favorable graft placement. Unfavorable pattern is long during flexion. And then we move to a little distal or posterior in the tunnel position. So results, the favorable pattern is 70% of patients. 30% patients are unfavorable if we put the femoral tunnel in the Shoto point. So the final position in the unfavorable group, 7 patients, 5.9 millimeter distal, and 6 patients, 6.3 millimeter posterior. So compare unfavorable group and favorable group. There's no patient background. Even the trochlea de jure type, there's no difference. So the graft length change pattern at the femoral tunnel position determined under fluoroscopic guidance, the 70% are favorable, however, 30% are unfavorable. So you should not decide the femoral tunnel position just a Shoto point. At least length change pattern needs to be checked before graft fixation. Otherwise, the patient cannot flex the knee. The tension is higher in the flex knee position. So why is the length change pattern at the position determined under fluoroscopic guidance not physiological pattern in some patients? The reason one is a technical problem. You cannot see the not true lateral view. Small degrees of deviation from true lateral view resulted in inaccurate position. And also reason 2 is anatomic variation. The optional position of femoral MPFL graft fixation is patient specific. The knee is very abnormal, so even you put the Shoto point, that is not working. So I show the case, 2 cases. Case 1, 24-year-old female softball catcher. She had both patellar dislocation, and the image measurement, patellar height is normal, sulcus angle is normal, congress angle is normal, and patellar tilt is almost normal. So no bony abnormality, but he has episodic patellar dislocation. So we did MPFA reconstruction in both knees, and she returned back to sports at 8 months post-op. She's fine. And Case 2, 30-year-old female, unstable knee, both knee, and first dislocation is 15-year-old, and recurrent dislocation getting worse after first dislocation. Right knee range of motion full, very unstable feeling when extend the knee. Apprehension is 2+, and unable to do straight leg raising. The alignment is a little valgus in right knee, and the patellar outer is very severe. And we check the CT scan, and the femoral neck anteversion is 54 degrees in right leg. So we are planning to do derotational femoral osteotomy. And if needed, we do MPFA reconstruction. We planned. Then we did the derotational femoral osteotomy. We checked the patellar tracking, and still patella is unstable, so we did additional MPFA reconstruction in this case. So the take-home message, the management of acute first-time patellar dislocation with MPFA reconstruction resulted in a lower rate of redislocation than in the rehabilitation group. So you should be very careful, check the predisposing factor for each patient. Using fluoroscopic guidance method of MPFA reconstruction, non-physiological unfavorable length change patterns were observed in about 30% of the knees. Surgeons should use caution when determining the femoral tunnel position using the fluoroscopic guidance method in MPFA reconstruction because patients' knees are not normal. Additional surgical procedures such as tibial tubercle osteotomy, trochleoplasty, etc. may be necessary to treat patients with severe patellar outer, trochlear dysplasia, and J sign. Thank you very much. Thank you for your attention.